Good afternoon, everybody. Welcome to our panelists. Welcome to our audience joining in. I know we have more folks kind of trickling in, which is great. Let's hopefully, we'll have good, good sort of audience over here. Just to level set for everybody before we kind of get into intros and content and all that jazz. This event sponsored by Health Gorilla, hosted here by Health Gorilla, is meant to be an opportunity to share perspectives across the industry on a particular topic. Health Gorilla is a platform for data exchange and is market leading in a number of different data content aspects and brings them together into a unified platform that enables usage in a variety of different contexts and settings, and hence we have participants who represent a few different contexts and settings. Everybody is welcome here. So if you are an existing customer or just an interested party, I mean, heck, if you're a competitor, like whoever you are, welcome. I hope you know that we're excited to have you here, excited to share with you what the folks here on this panel know. And please, at the end, we're going to spend some time on Q&A. If you have questions that you'd like to raise that would help increase the value and the content knowledge for everybody involved here on the webinar, please ask. We would love to be able to keep talking about this really important topic, which I'm about to introduce momentarily. One note, these webinars are hosted by Health Gorilla as somewhat of a public service, obviously, but also an opportunity to share the topics that we are focused on as well as a company. This particular group, this group of panelists that you have here today have known and worked with each other, over a number of contexts over the last decade. So we have done no practice coming into today's discussion. That was a little bit deliberate, but it was mostly just because we have really packed schedules, all of us doing what we do. So the luxury you're going to have today as an audience member is you're going to learn brand new insights, hopefully, from a variety of different perspectives. And what's funny about that is we'll also have that same luxury, as we'll probably learn some brand new perspectives from each other, having never worked on this particular topic together as a group. So with that in mind, I'd like to do some introductions across our panelists here. Panelists, I'll call each one of you out. Just please do a self-intro. We'll go through. I'll intro myself last and then get us into the content for today. That's good with everybody. Farah, you're at the top of my screen. May I just start with you?
God.
Down my screen.
Absolutely. Hi, everyone. My name is Farah Saeed. I work at eClinicalWorks, and I've been in the interop space for about 11 years now, mostly on the business development side here with ECW, with our interop strategy, but dabbled in a little bit of project management way early in my career, and happy to be here and share the thoughts from the perspective of an EHR vendor.
Perfect. Thank you. Dr. Stephen Lane, may I pass that on to you?
Absolutely. Thank you, Jitin. My name is Stephen Lane. I'm a practicing family physician and clinical informaticist. As you can see from the shirt, I now work at Health Gorilla for the past 7 months or so as the Chief Medical Officer, but I've been working in the health IT space for 30 years. For about 20 of those focused on interoperability. I am a longtime user of a large EHR system whose name starts with E, and it's not eClinicalWorks. And I have a lot of personal experience with ADT alerts, being the recipient of those and occasionally part of the generation of those. And really interested in this discussion to sort of dig into how we can improve the utility of these alerts. I also have had the pleasure for a number of years of working closely with the ONC and a number of other national interoperability initiatives, and really, hearing from a lot of different people about both the value and the challenges of managing ADT alerts. So can reflect some of that back as part of the discussion.
Terrific. Thank you. And Chris, I can pass it to you.
Thanks, Jitin. Good afternoon, everyone. So Chris Pugliese, I'm the Director of Product Interoperability for ResMed SaaS, which is the holding organization for a portfolio of long-term post-acute software products, so EHRs and other delivery, service delivery tools. And I oversee the interoperability portfolio, and I also sit on the post-acute interoperability leadership team, or PASIO for short. Anyone interested in joining, please join us.
Terrific. Yes, plugs are always welcome, especially if they're authentic, which is perfect. So I'm Jitin Asnaani. My name is Jitin, rhymes with kitten, for anybody who feels too intimidated to ask me how to pronounce my name. I am a board member of Health Gorilla. I'm also a board member of the State HIE of Maine. I have been involved in interoperability for the last dozen or so years, basically the time I've spent in healthcare, starting in the Obama administration, where I led a number of standards activities there, at Athena Health, where I was a director of product innovation in interoperability, and then leading CommonWell Health Alliance before working finally at Patient Ping, which became Bamboo Health towards the end of my time there. And then in the last year or so, I've come to work here at Health Gorilla more of my time. I have a floating title, so I think we're calling me executive advisor, but I play a number of different roles across the company, as well as, like I said, being on the board. So I'm very excited to have everybody here. And actually, Dr. Lane gave us a little bit of intro into the topic. And just to level set for everybody, in case you're not familiar, in ADT is an admission, discharge, transfer. Notification. It's often called an ADT data or ADT notification or ADT alert. So it all comes to the same thing. Sometimes it actually includes events beyond the ADT, but it is those admission, discharges, and transfers which are most important. And what I'd like to start off with is I like to look at U.S. healthcare, despite all the pieces, sometimes dysfunctional pieces that sort of kind of come together, but they don't. It always, in my mind, comes down to what is the value of anything we do as tech vendors, as provider organizations, as any of the pieces of the ecosystem puzzle. What is the impact on the patient, and what is the impact on the relationship between the patient and the provider? ADTs are interesting. They are one of the few types of data elements that actually has a timeliness component to it. There's literally embedded in it this notion of a time, right, as a notification that an event is happening. And I'd love to unpack a little bit, and maybe Dr. Lane, I can start with you to help us start thinking about what does an ADT mean for the care of patients and for that provider-patient relationship?
Yeah, and I'd argue, actually, Jitin, that there are a number of other things that have timeliness associated with them. Medications come to mind, but be that as it may, I think the alerting related to care that's received by an individual is really very valuable if you are involved in managing a patient's care. If you have a holistic perspective of a patient, if you have some responsibility for their health outcomes, their financial outcomes, et cetera, it's very important to have a real sense of what's going on with them, basically. And you can know what's going on with people in a number of ways. You can learn about bills that have been submitted or paid. You can learn about medications that have been prescribed. But with ADT alerts, you're mostly learning about pretty important events in the care of a patient. Typically, they show up in or leave an acute care facility, be it the emergency department or the hospital itself, or they are transitioning their care from one level of care to another. So as a family doctor, I'm all about care coordination and primary care and having a holistic view of my patients, regardless of the payment schema, right? I've always cared, even before there was value-based care, I've always cared about knowing what's going on with my patients, right? Because if my people are sick, they probably, I want to know that. I want to think about it. I want to coordinate that care. I want to optimize that care, make sure they're getting the right level of care. And if you're in a value-based care arrangement, that need just has a whole other dimension, which is the financial dimension. But I mean, whether you're thinking about just the optimized care of an individual or how the value is being driven through that process of care, you need to know what's going on. And by knowing what's going on, you can try to impact it to make that care as valuable as possible. The lowest cost, the greatest benefit, and the best coordination across all the care that patient is receiving. So I think that's, to me, the big picture of the ADTs.
That makes a ton of sense. And, I really appreciate this. Is where I wanted to start here with not only a physician, but particularly conscientious physician, as you have been for the last 30 years of practicing across the health system. Farah, let me turn to you and get from your perspective, working at an EHR vendor, having to think about this from the perspective of a broad spectrum of ambulatory physicians. How do you look at the ADTs and the impact they have on patients and providers along with their patients?
Absolutely. The great thing about ADTs is they're one of the few of these common interface mechanisms that we have that's actually a push model. A lot of what we're familiar with, care equality, CommonWell, health information exchanges, all function on a pull. I have patient John Smith in front of me. Well, what's going on with that patient? And at that time, we go out, we search for data, and we pull it in so that the provider can get that holistic view of the patient. But the great thing with ADTs is they function on push. So my patient was in the hospital just now. They were admitted, they were discharged, whatever might be happening. ADTs are one of the few common, now kind of common integration types that's actually pushing that information directly to the provider. They don't have to go searching for it. They're just proactively informed, which is really important, of course, with that transition of care, with knowing what's going on. Even if it's just a heads up, if we're not getting super technical into these terms, you just need to know, maybe you want to pop in and see them while they're in the hospital. You need to, you're the cardiologist. You want to make sure everything's being taken care of, even though they just have a broken bone or whatever it might be. So that push aspect of being notified is really unique to the ADT alerts and of great value, we feel, to all of our physicians.
So that makes a ton of sense from the perspective of, especially as you look at specialists, the family physicians for sure, but as you look at specialists, these ADT alerts can actually have a ton of value in terms of guiding that provider-patient relationship to be stronger. Actually, one of the issues we have in healthcare is technology has actually separated that relationship, right? We spend more time looking at screens, less time actually working and having quality relationships between providers and patient, quality interactions. So this can actually bring that element back and at exactly the right time that it's needed. That makes sense. Chris, I'd love to hear from your perspective. Your ResMed SaaS covers a broad spectrum of post-acute care. You couldn't go through all of it in your intro because it's a vast portfolio. How do you think about ADTs and just where they're most impactful in the care of patients among the providers that your system serves?
Yeah, so post-acute a little bit different here again because we're outside of the four walls of any kind of healthcare facility in some cases. And let me actually just go all the way down into a specific anecdote that every year is costing various healthcare providers and systems millions of dollars. Is you're a home health nurse or therapist or whatever it is. You're going on your routine schedule of the day, 4 or 5 visits, and somewhere in the middle of the day, you knock on a door and no one answers. This happens daily, hundreds of visits, thousands of visits across the country, more than that probably. And the reason that they're not there is because they went back to the hospital. And there is no forewarning that that's going to happen. It might have happened overnight. It might have happened the day before. And the last thing on a caregiver's mind or a patient's mind is, I should probably call those people that come and visit me. As far as they're concerned, it's all part of one healthcare delivery network. So why don't they know? So having those kind of notifications routed to a post-acute provider can be a key saver. But also just an operational efficiency and allowing more care to be provided to a patient that is home, for example. Resources are already stretched. People are already trying to provide the most care they can with the fewest possible nurses. So if you have a missed visit, that's just a wasted revenue stream as well as a waste in the overall ecosystem. So same thing to a certain degree in our nursing facility scenario is a little bit different, where they are inside of 4 walls of a facility, and they're the ones who actually, put the patient into a gurney and help them into the emergency vehicle. But they don't always have the visibility as to what's going on. What did they ultimately admit for? They aren't necessarily doing the assessment. So being outside of the kind of major prescriptive area in the acute and ambulatory setting means that the ADT can bring post-acute into a tighter step with the overall delivery of care in those acute and ambulatory settings.
It's interesting, right? I remember when I was actually, Dr. Lane, I'll just real quick comment. I remember back when I was working at the ONC and we were implementing at that time meaningful use for those who still have the scars and remember it. One of the challenges was just given the way that the funding was set out and the like, and I won't go into the technicalities, most of which I don't even remember anymore, but it kind of segregated the world into acute, ambulatory, and post-acute. And the bulk of, at least at that time, the funding and the energy went into acute and ambulatory and getting those two work together. And post-acute, as vast as it actually is, was left high and dry to a large extent by that initial set of work. We've seen over time as that's happened more and more, but it's really interesting how this, and you said it almost as at the four walls. You said you started by saying it's outside of the four walls of healthcare, as if it's not healthcare, but it's a huge part of healthcare. But you're right. The mentality has always been, oh, there's acute and ambulatory, and that's where the work has been. So I was very excited as you joined us, Chris, because it's just like let's talk about real healthcare, which doesn't just stop the moment the patient has that provider visit, right? Like they go to their homes, they go to the nursing facilities, they go to community resource centers, they go elsewhere. And care has to continue through and actually be connected. I'm sorry, Dr. Lynn, you were going to say.
No, that's fine. No, Chris, you just you triggered in my mind just this image of a patient, an individual at home receiving home services. The home care person comes to the door and knocks, and there's no answer. Well, they might have gone to the hospital. They might have fallen, right? And they might be inside needing care more than ever. It seems like, are they going to call the cops? Are they going to break down the door? Are they going to start calling the family? I mean, not only is it inefficient, but I mean, it really matters in terms of doing the right thing and getting and optimizing the outcome there. So I hadn't thought about that scenario as you described it. So thank you.
So let me take a quick step back. So, as some of you are aware, Health Gorilla recently announced their real-time ADT network with more than 1,600 hospitals across the country connected to it and providing these real-time ADTs. And we're very excited about that. It's going to be available to providers, to payers, to others in between, and then particularly this growing space where the two intersect, the payvider space, for lack of a better term. I almost want to put air quotes around it, except I hate air quotes, so I'm not putting it around. But like that but there's this broad spectrum space, right? But it's particularly, and Dr. Lane, you mentioned this, you alluded to this at least briefly in your opening remarks, that there is regular care and a regular conscientious provider cares about their patient regardless of the service model. That being said, value-based care is becoming more prevalent, and certainly very much so in some parts of the country and probably more nascent in other parts of the country. But no doubt it's still secular and it's increasing. How do you think about the value of ADTs increasing, decreasing, changing, improving from the perspective of value-based care, and in particular? And I'm happy to start. Maybe Dr. Lane, since I started with your comment on that, maybe I turn it to you to give first crack at it, and we'll rotate a little bit more among everybody.
Well, of course, as we all know, in value-based care, one of the key factors is keeping the price down, right? And optimizing the outcome. I mean, and again, and that's always been the case, as you say, in the conscientious practice of medicine. But at least here there are financial incentives that end up being aligned. And if you're going to keep the price down, you have to make sure that people are getting the best care from the right facility. And I think especially in value-based care arrangements, the right facility has everything to do with who's in the arrangement, who's contracted. So oftentimes there is a need to direct care to the providers of choice, be it to the right hospital, to the right post-acute care setting, to the right specialists, et cetera. And even whether or not somebody gets admitted to the hospital. I mean, when a patient splashes down in the ER, sometimes it's obvious that they need to come right into the hospital, but other times it's not so clear. Maybe they could be set up with intensive home care. Maybe they could be redirected to see a PCP or specialist the next day. Oftentimes, if you don't have a network of care in place, people just end up in the hospital by default. And we all know that that has risks and costs and things that we would rather avoid if possible. So I think when you're looking at the whole value proposition of the care, it's particularly important to know what is happening, whether people show up at the hospital, leave the hospital. Then there's the whole challenge, of course, of readmissions. When people leave the hospital and they don't have a full suite of necessary services set up for them, the chances of them bouncing back go way up. So I think both on entry and exit from the hospital and on planning those transitions of care, having all of the components aligned in a value-based care arrangement is particularly important.
Absolutely. That absolutely makes sense. Both from a transition to care, hospital readmissions, huge drivers of cost, particularly in focus areas of value-based care arrangements today. Why don't I switch it up a bit? Chris, I don't know to what extent you interact with value-based care. Why don't you share a little bit there, and as well as how you look at this perspective?
No, and Dr. Lane alluded to it already. It's actually almost like a business prerogative to a certain degree for a post-acute provider, right? Because unlike acute and ambulatory, we don't have many walk-ins, right? They're referrals. They're almost exclusively coming from a healthcare system. And the competition for those referrals has shifted away from kind of the good old days of bringing donuts and coffee in the morning and shaking hands to what are you going to do for me to make sure that that patient doesn't show up again? Can you show me that you've completed all the right assessments? And so when you put that in the context of an ADT, receiving a discharge notification from a nursing facility or a home health provider, oh, thank goodness. They made it through rehabilitation. They've left, at least for this cycle, the healthcare system. And that might be a point of doing chart reviews and assessments and saying, okay, we're going to pull the discharge summary information from whomever else based on this discharge notification we received. So on the one hand, that's the big role it plays. It's a competitive advantage for home health, for nursing facilities and other long-term post-acute providers to demonstrate how they can be valuable as part of this larger kind of value-based world we're entering into. But I should also note, and this other point here, because post-acute tends to be a very a higher risk pool of patients, right? The average age is much older. We're dealing with a higher cost population overall, which means there's a lot of risk pooling starting to go along these ways to create these payer plans that are part and parcel of the provider themselves. And having the ADTs as the kind of web that's connecting all these different overlapping services, because another kind of unique area of post-acute is you tend to have a lot more overlapping service where two or more providers have responsibility for some aspect of care at the same time. So having these sort of mapped notifications that show you when they started, when they finished, what the average length of stay in a facility was, whatever it may have been, to a payer or somebody trying to model risk to provide payer services, that kind of information can be vital, right? Just knowing that average utilization of a patient going into a post-acute setting where you might spend 6 months to a year rather than just a few days or a week in a hospital setting.
That makes sense. That's wow. So I didn't actually realize the overlap with the post-acute world was quite that extensive, but it's down to a business prerogative is kind of how you look at it. Actually, which is okay. That's I told you that today's a day where not only the audience but the actual speakers are going to be pulling away new insights. And so for me, that's the one that I totally underestimated until this point. Farah, I'd love to hear your perspective on it. The eClinicalWorks client base is incredibly broad.
Yeah,
it includes
absolutely.
A wide variety of ambulatory physicians engaged in a variety of different kind of care models and so on. How do you think about this and how ADT is playing, particularly from a value-based care perspective?
Yeah, absolutely. So I feel like, especially with value-based care, as Dr. Lane explained, keeping the price down, keeping the health of the patient high, a lot of that burden often falls to the PCP, the primary provider responsible, generally conceptually, for the overall health of the patient. And we've got a ton of PCPs on eClinicalWorks. On any ambulatory system. So, from their perspective, it's so key to know that patient has gone in and what's going on, because often they're the ones responsible then for that follow-up care, for making sure that, okay, the patient's been discharged, he had a serious surgery, he had, an extensive event, follow-up care. Are they taking their meds? Are they, following up with their diet, whatever it might be? And as we all know, humans, patients, we're all people ourselves, not necessarily the best historians, and not always the best at following up on what we need to do. You might get discharged from the hospital. It's like, oh, that was an experience. I don't want to deal with any more doctors anymore for some time. And they won't follow up with their PCP necessarily, at least immediately on their own, or, people just need a break. They just need to be like, oh, I don't want to think about this for a little while. And that's where ADT alerts come in and are so beneficial, because the PCP or, any providers proactively being notified of that event. They can then reach out and perform those services and do what they need to do to help the patient help themselves. And, at the end of the day, bring that value, bring their healthcare up to help that value-based model that they're all in at this time.
Makes perfect sense. Makes perfect sense. Actually, I'm going to key off of that to ask you the next question I had in mind.
Yeah.
That actually, I think you almost started with your very first comment. But before I go there, let me take a quick step back. I'm seeing that there's a fair bit of engagement in Q&A and across this webinar, which is incredibly exciting. Let me just, since some folks joined a little later than my early start, let me make sure I point out two sort of public service announcements. One is we will do Q&A at the very end. So if you have questions, please put them in the Q&A panel. If we can answer them offline, one of our team members will answer them offline and you'll have your answer. If not, we'll bring it up during the Q&A if we find ourselves with enough time to cover them all. The second thing is just a reminder. So we as in Health Gorilla invited other panelists to come and bring in perspective, because we wanted to share a broader set of perspectives on this important topic around ADTs. We just announced our release of our product over the last couple of weeks. I want to make sure for everybody's benefit, they understand that that doesn't imply a commercial relationship between the panelists all over here. So Farah, I noticed there's a question that's there out there for you, like why are you working with Health Gorilla as opposed to anybody else? So feel free to answer that as you feel fit when we get to the Q&A perspective. All right. So just want to make sure everybody understands this is just an industry discussion, and we happen to be very blessed here at Health Gorilla to have Dr. Stephen Lane as our CMO, but we wanted a great physician IT specialist to come and join us, and he happened to be right here in house. So that's how we ended up with him on this panel as well, along with two guests. All right. Question for you. Here's a question I really want to, actually, this is sort of the heart of the question that I really wanted to ask at some point. So I will make it brief, but bear with me because it's a crunchy one. The question I had for you is, having spent some time working with ADTs in two previous lifetimes of mine now before Health Gorilla, they can be incredibly fatiguing. If you have a panel, like an average size panel of, which numbers, usually typically north of 1,000 patients per doctor, right? And sometimes well north of that. If you were to get alerts from them, particularly in situations where you have a lot of patients with comorbidities or other things going on, which means that they're actually having a number of events across the ecosystem, that can get really tiring. How do you think, as eClinicalWorks, as Farah, as yourself, how do you think about enabling that to be managed in a way that is productive and more productive than it is distracting, which doctors already have enough piled up on their plates, is my interpretation from watching my wife practice, and she's a practicing infectious disease.
Absolutely, and thank you for asking that. It's something I feel strongly about. I think as a company we do as well. But I think there are two parts to it. One, as the EHR vendor, as kind of the mechanism for how providers are going to be seeing this, I think we have a responsibility to be presenting it in the most streamlined, clear, non-offensive way possible. So to that effect, I know at least, within our system, we have a dashboard, we have a basic dashboard, we have a more intense module. As long as the messages are coming in formatted a certain way, we can pull them out, we can attach them to the right patient. We can say, this is an admission versus this is a discharge or transfer. If the information is all consistent, we can put the admit together with the transfer together with the discharge. So it's all together in one place. So when a clinician is going to look at it, they can see, okay, this is the full circle for this visit for this patient. Ideally in the same place, they can see the documents that come along with that. So I think how that information is presented is really key to reducing the burden on the clinicians. But going hand in hand with that, the way to make that happen, to allow us as a technology vendor to display it in the easiest way possible, there has to be consistency as to how these are sent industry-wide. And that's something that isn't fully there yet. I think we're all in the process of getting there. You know, we have strong opinions on this as a solo receiver of this data. You know, ECW being ambulatory only, we're not doing admits and discharge, so we're not pushing out any of these. So we're just a catcher. We're sitting here with our giant catcher mitt, trying to get anything that's thrown at us. And that's why we feel that the ability to standardize so that all vendors, all, you know, all different systems who are consolidating these messages and sending them out to us are all in the same format. You know, everyone's agreeing that if it's an admission, this is what you say. This is where you plug in the diagnoses codes, et cetera. I think having that consistency for these notifications is really going to help us break it down in a clear way to reduce that burden for providers, for clinicians.
That makes sense. That makes sense. So what you're saying is on the sending side, you would expect more consistency. And of course, that can come from the source itself, or it can be standardized somewhere along the middle, such that what you receive as with the catcher's mitt is predictable, so that you can actually do something intelligent with it. Chris, I'd love to hear your perspective as to, you know, how do you think from a systems perspective, looking at ADTs and turning them into more information than noise, which is the challenge with ADTs?
Yeah, I think there's actually a pretty good, you know, adjacent problem in labs, where you have the same scenario where you got constant lab results coming in. They may be out of range by whatever definition that lab or that health system has for out of range, but that may be completely immaterial if that person has XYZ condition. And ADTs are the same thing, right? It could be completely immaterial depending on all of that additional context. So helping to the role of an EHR, like the ones in my portfolio, or I think what Farah is also alluding to, is just how do we provide that context to our users to make only the ones that are meaningful available? Otherwise, you do end up with this inundation of information that 70, 80, possibly even 95% is not really usable because of the sheer volume and probably no real intervention needed by any of, you know, that provider's team. And providing context is always difficult because it's going to be very centered on the population you're working with. For example, if you've got like higher rates of XYZ respiratory disease, well, certainly an admission for a respiratory emergency is going to be much more relevant to you than maybe something that seems a little bit more benign or less routine for your area, less of a focus of your practice or of your organization. So that context goes from provider to provider, and all we can really do is help provide the right tools and capabilities for providers to tune their own context, because there is no standard context. Every region is different. And so that's, I mean, the biggest thing and this applies, I think, across healthcare, post-acute or not, is how do we provide that context and what data can we pull out? And I do believe that there is the right data in an ADT. You've got to be a little creative maybe and focus on stuff in the MSH segment, which no one wants to do. But there is an opportunity just about finding that right balance between getting people the right information, but not overwhelming them with the wrong information.
And a reference to a segment of an HL7 file finally comes out.
I know, I want to be the first one to use an acronym.
All right, Dr. Lin, I'd love to hear your perspective as a practicing physician who let me actually ask you the easy question first. As a practicing physician, have you been in a position where you actually do receive ADTs?
Oh, absolutely. Absolutely.
So how do you manage it? I'd love to hear your perspective, both either from a system perspective, from a practice perspective, from a best practices perspective. How do you think about managing ADTs such that they're valuable from, in terms of the work you've done?
Well, first thing, I really want to thank Farah and Chris for describing how you're approaching this, because, you know, ADT is just sort of launched on the scene. I don't know what it was, like 5 years ago, you know, where we started getting these, you know, maybe it was more now, because I think COVID time sort of is unreasonably represented in my memory. So maybe it was 7 years ago. But the point being that they just started showing up, you know, in the in basket. It's like, what's this? You know, inbound messages. Oh, my patient's in the hospital. Oh, my patient's in the ER. And really at first there was no filter. There was no selectivity. It was just like, if my name was on this message as the PCP and the patient matching worked and my system worked, you know, some subset, I have no idea which subset, made it all the way to me, you know. And it's like, oh, wow. Do I have to do something about this? You know, I'm just a conscientious primary care doc, right? And what I started doing was calling the patients, you know, finding out what's going on, asking my staff to bring them in for an appointment, you know. And then, you know, as we started realizing that just wasn't going to be scalable, you know, I mean, if you're an internist, geriatrician, you know, whatever, cardiologist, I mean, as you say, you could be getting these for a substantial proportion of a panel of patients. So I think there's been an increasing awareness of the need to be able to standardize, to filter, to route, to use these as triggers for additional steps in an information exchange process. But I think that, you know, it's critical to think about what is the role of the user. I mean, a PCP, that's just one role, right? I mean, there's care managers, there's nursing staff, there's scheduling staff, there's all sorts of other folks who may be involved in the care of a patient who should be receiving these perhaps instead of or in addition to, you know, the provider themselves. As you were saying, a lot of them are going to be, you know, more or less significant depending on the diagnosis, the context, the specialty that's receiving them, you know, the time of year. You know, I mean, are you getting an ADT for every infusion visit, or you know, that a patient, or allergy shot that a patient is getting, as opposed to, you know, being admitted to the ICU? I mean, those are very different. So I think there's a real need to be able to get that contextual data in discrete fields so it can be used for filtering and routing and triggering other events. And then I think one thing that I think is missing, and frankly, I think perhaps we need to add to the US core data for interoperability, is just that needs follow-up. You know, just a discrete flag that says this person needs something. They need home care, they need to be seen by their PCP, because when you're discharging a patient, it's like you can bury that inside the discharge instructions or the discharge summary, but that you're not going to be able to pull that out, you know, through an LP and use that for routing. I mean, we need a few really agreed upon discrete fields that will make these even more valuable and even more, you know, give us the capability to route them and use them more effectively.
That's very interesting. You know, I've previously seen, you know, inferring whether or not a patient needs follow-up based on their history. You know, have they been to an emergency department more than once over the last 90 days, for instance, right? Very common way of articulating what the urgency is for, like, actually making sure this patient gets, you know, in future follow-up. But in many cases, the provider that's drove the last event, the event you're being notified now, actually does know whether this patient does need follow-up or not. And you're right, as far as I know, it's not a discrete data field captured anywhere. And maybe USCDI, the core data set of discrete data that is espoused by ONC and is being eventually built into all EHRs. Maybe that is where, like, capturing such information should be discussed. Well, we're very lucky that we have you, like, as part of participating, that you are participating there with some of these committees working through these thoughts, because clearly that seems like an idea that needs to be, you know, kind of driven through and discussed. Let me ask you one other thing though. Off of you mentioned a host of improvements you've seen from that time when you just get a smorgasbord of ADTs landing in essentially your inbox. To what extent have you seen automation play a bigger role in actually enabling better care, more efficiency for the practice, eventually bottom line better, you know, better performance for the practice as a whole? Have you seen any of that happen? Do you anticipate any of that happening in the near term? That's, you know, now if as ADTs become more of a ubiquitous commodity.
You know, it's interesting because as a provider, if things are being automated, I frankly don't know about it. I mean, as an informaticist, I know about some of the things that we put into our system to reroute messages or to block messages. But I'm really interested in hearing from Farah and Chris about what you're building for that automation, because I think it is critical. We need to automate these steps. We need to streamline the workflows so you don't have humans, especially multiple humans, having to touch these things along the way.
Farah, you want to take a step?
Sure. You know, I'll be very honest at this point. We have the dashboards, and I think we are still seeing all those messages come in. You know, we're starting to get the initial ones in. Our transition of care management module just went live, I believe, last year. And we're still trying to get feedback to see exactly like you said, which one of these can be automatically, you know, put into a less urgent bucket, into a more urgent bucket. You know, we do have controls in place to reroute. So one provider doesn't want to be the first one who sees it. So he or she can designate an assistant. So, you know, at each level, those can go to a secondary person to review first. So we have things like that in place now, but we would love, especially like you said, with something like this follow-up flag, it would really allow us to do more with that, to be able to say, okay, maybe we have separate tabs. These are more urgent, these are less urgent. So we are still delving into that area of more automation, or at least more auto reviewing, you know, working in, if possible, any AI into that, into reviewing, into things like that. You know, we don't have that in the ADT spaces yet. But, you know, on the EMR side, I know we're working on summarizing CCDAs that are coming in from these nationwide data sharing networks already. So expanding that as well into this space is definitely something we will be looking into doing soon, because of course, nobody likes to read through a 25-page patient level CCDA that has 5 years of data for that patient coming in. So, you know, summarization, things like that. And then, of course, one thing that we do have in place right now already is our search engine. So not automation, but again, just trying to help clarify, to help get all those additional pieces of information for the clinicians as they're looking. We have a discrete search engine that will allow a provider to go in and say, okay, has this patient had any MRIs in the past? Have they, you know, has anything else been going on? Or, you know, I think this is related to their diabetes. Let me type A1C and find out some more information. So we allow them to discreetly search that, and it will search all of those external records that have come in from the various sources. So we are definitely very interested in trying to make all of this excessive data, which they need, which, you know, it's not our place to necessarily say what's important, what's not, but giving them the tools to better analyze that themselves.
That makes sense. And that jives with what Chris had suggested earlier in terms of giving them, the users, the tools to be able to choose what they need. Dr. Lane, I see you have your hand up. What would you like to?
One of those tools that I think it would be good to give the users is the ability for an individual user to specify for an individual patient how they want future ADT messages to be managed. You know, for this person, I really want to hear every single time, even if it's a Sunday morning, page me, you know, I'm really engaged. Whereas for this person, I want them to go to Carlos, you know, and Carlos can deal with this person, you know. So, I mean, I think that would be really helpful, that user specificity.
That makes sense.
And that's definitely something we've heard and we are working on.
Chris, what's the way you've thought about automation to extend? You know, automation is still, I think, a little bit more leading edge. I'd love to hear how you guys have started thinking about it and if you're doing anything on that front.
So we have, as we've talked about a couple of times, just a bunch of different platforms in the portfolio with varying levels of implementation. But as an example, and I'm going to try and answer your question, Dr. Lane and Jitin, and as well as one of the ones in the chat about which part of the MSH we look at.
Yes.
So at one of the places we've implemented ADT, we pay attention to the timestamp because in home health, an ADT that occurs maybe a couple months after the patient discharges absolutely might still be relevant to that home health provider. They may have gone back to the hospital. It may have been related to the original diagnosis. They may want to start doing outreach to the family or the caregiver to resume care in the home, or even in a facility scenario, ultimately leading to home. So we pay attention to the times and to a certain degree, even the provider identities, but you can get better information or more specific information in the PV1, just to keep naming segments. As far as automation, absolutely. I mean, one of the kind of longer goals and what the ADTs represent is information being available. Maybe not for the admission, although you can get documents generated pretty quickly when someone's going through an acute event. But at discharge, right, that's an indication, hey, anything that might be relevant to the future care that this person's going to be returning to, especially in those facility contexts where they're going back to a building that is their residence. That information is highly relevant, and be able to automatically just bring that in. Hey, they just updated all their meds for their new condition. Let's just bring all those meds in. Certainly lots of other scary things that have to be taken care of to do that with meds, but you get the idea. We'd be able to real-time update the patient record. And that's where we want to move to in our post-acute world, is as the more active is the wrong word, but the kind of shorter period of time of activity where everything happens in the acute or ambulatory space, that we can get access in that kind of timeliness point from the beginning manner to all that information that is very clinically relevant to a given patient.
That makes sense. That makes sense. So looks like there's a fair bit of automation to think about in terms of the system, as well as there's opportunities to get us there by getting more consistency. I think, Farah, you said consistency from the senders. Chris, you're saying the right set of tooling on the front end, and more we can. Dr. Lane, you're saying that to the extent you're doing automation, you're getting more work out of my hands. And clearly, we have a lot of work to do on all the fronts. It sounds like nobody has nailed it. And I think a couple of the comments in the Q&A also suggest that hey, are we saying that there's not, great standards here? And to some extent, there's certainly not perfect standards here. There could be more. And there's clearly more opportunities to add more data, to Dr. Lane's point, or to get more consistency, to Farah's point. All right, we should start opening up the Q&A. I had one last question. Actually, to the large extent, everybody has touched upon this. So why don't I just give everybody one more chance to add a point here, which you feel is important or not. As Health Gorilla, one of the things we're excited about is we have this clinical data exchange network, EMPI, RLS-based, completely based, person-based exchange network, connects to all the big national networks, and it's going to be a QN in its own right, connecting to TEFCA as that comes online later this year. We have a lab ordering network, we have SDOH data, we have pharmacy history data. So we have other sources of data as well, right? I want to go through the list over here. As we think about ADTs and how that ADT data becomes more valuable when juxtaposed and used in tandem with other types of data, what are the things that stand out to you? What is it you're thinking? From your perspective, seeing what your users have done or yourself have done, and maybe in Dr. Lane's case, looking at both as angles, what is the combination of the ADT plus the right set of data that is incredibly valuable to the patient, the provider, the payvider experience, from any of the angles of the triple aim that we're constantly striving to achieve. Chris,
I'm happy. Let me
start.
Yeah, please.
Go for it. Chris, I almost started with you. You are lucky. You just dodged a bullet there. Go for it, Dr.
Well, I mentioned earlier that I think that ADTs should be able to trigger additional events, additional data queries. Farah was getting at this in terms of saying, well, let's put it in the context of the record. Let's bring that data together so that you can see it all for the patient, which I think is a great first step. But really, ADTs for the most part are pretty skinny. It's like something happened somewhere, but they don't necessarily tell you what happened. So I think that as a provider, when I get the ADT, the first question I have is, well, what happened? And then I'll go out and I'll do a query and I'll try to get that discharge summary or look at that ER note that may still be in the process of being written just to get some clue. So I think there really is a way that we should be using ADTs as triggers to seek out the right information for the user who's getting alerted, be it a care manager, a PCP, a specialist, a home care person, so that you can not only collect, but then manage and present just the right data they need at the right time to make their decision. And I think that's going to be very user dependent, but we could do it. We could say, gee, if you're a cardiologist, and you get an ADT for a hip fracture, you may or may not be, care unless this person is anticoagulated, in which case you maybe care a bunch, So there's a bunch of rules that we could write into that to say, what data do I need to do my job, with this ADT, and get that and present it up front. That's my thought.
Makes sense. That makes a ton of sense. And actually, I think that answers a couple of questions people have asked about the ADT. I'm looking at the Q&A now, and as I think about that in terms of the ADT and how would you bring it alongside other sets of data, and make up for the fact that, I like that term, Dr. Lane, the ADT is kind of skinny. It is very skinny. It really doesn't have a ton in it. But once you put it alongside the ability to query for SDOH data, the ability to query for clinical data, the discharge summary. I think, Chris, you mentioned in one of the examples, if I got the discharge ADT, a very natural thing for me is to get the discharge summary as well, which gives me the other information that tells me what happened to this patient in more detail. Before I turn it over totally to Q&A, any other similar examples or examples that sort of top of your mind? Farah, you look like you're about to say.
I was. I just wanted to add to what Dr. Lane was saying, about the ADT being skinny. It's the where and the when. But what's really important to most providers is the what else, is the why. And that's why, from our perspective, we'd really like to always see that discharge summary with it, if that's something that could come over. And I think I just glanced at some of the questions. I think one of the questions in the chat was, is there really no standardization? And I wouldn't say there's no standardization, but there are some guidelines. People can do ADTs, just straight point-to-point ADTs. Folks can use direct messaging. There are a couple different standards out there, but the key is kind of, amongst all of those, when you send it, will you also send the discharge summary? Things like that. I think that's really important for us to get. Otherwise, we do have to go out and query for them, of course, which is there in most of our systems as well. But the ability to get all of that together is what will make it truly meaningful. And then, on the part of the technology system, ours, Chris's, all these systems, the other e-vendor, just how are we then making that visible, and how are we showing the ADT side by side with the other external data and your internal system data? I think just bringing it all full picture is really what's key.
Terrific. Chris, anything else you'd like to add? You actually brought up much of your response during the course of the other discussions topics, but I just want to make sure you have an opportunity to share anything else you'd like to add.
No, I'd echo what Dr. Lane and Farah have already said. I mean, it's that context we've been talking about is that additional data, right? So sometimes you need that to make the decision as well. So there's always going to be a need to pair the event with information and to make those decisions. So that's, the next horizon, the next avenue to pursue for any health IT focused individual is, okay, well, how do we make it meaningful, and what data we need to do it?
Perfect. Okay. Well, I'll tell you what. So we only have a few minutes for Q&A. So what I'm going to do is I'm going to pick off a few of the questions. I'm going to more or less try to go chronologically, but just understanding that some may lead to discussion, some may not. I'm just going to jump around a little bit. Mr. John Nordstrom has asked a number of detailed questions around the technology, and I want to respond to that and say that for healthcare works with the whole alphabet soup of different standards. I think it's fair to say, having worked in an EHR, and I think for us in a similar boat, and Chris, you as well, you also learn to work with a whole alphabet soup of different types of messaging that you get to. Especially the larger the EHR, the more you've had to deal with every variety of IHE, and thankfully more and more RESTful basic protocols, FHIR in particular, recently, and the smorgasbord of the 13 ADT types of messages as well. So there's certainly a broad set of different messages to, unfortunately, we are not in a world yet where all the standards have consolidated. But on the other hand, they also have different purposes. And so across the industry, we have to support a number of them. There was a couple of questions asked around the relation between the ADT world that we're talking about today, and TEFCA and QHINs. And Dr. Lin, I'll ask you to correct me if I'm mistaken, but I'll take a quick stab in the lieu of time and say that today, TEFCA does not really encompass the sharing of ADTs. It's primarily about query retrieve. There is a push-based aspect to it, but to the extent that how that is going to be utilized yet, I'd say it's fairly undefined. I do personally, just taking a step back, I personally do think TEFCA and that framework of trust that's built around it is a fantastic set of scaffolding in which to expand beyond query retrieve into ADT sharing, which would alleviate a lot of the friction we see in healthcare in terms of sharing ADTs and signing up for ADTs from one place to another place, etc. But that's just my perspective. Do you have anything else you'd share? I know you've been a lot closer to the whole QHIN endeavor on Health Gorilla's behalf.
Yeah, I mean, I agree with everything you just said, Jitin. I do hope that TEFCA push messaging will evolve and that we will see substantial uptake and specific use cases. I think ADT messaging would be a great one for TEFCA push messaging. There are other examples in the public health space, just care coordination generally. You know, we as an industry have really struggled to make the most use of direct messaging, you know, for some of these use cases. And I think seeing which of those can transition to TEFCA and, as you say, benefit from the entire trust framework that's going to be growing up around that will be very helpful.
Absolutely. All right, terrific. Now, I noticed I'm just looking at a couple of these questions, and I realize a few folks are asking about Health Gorilla's new offering on the ADT front. What I would encourage folks to do is to look at our website. There's also on the very front page of our website, there's a button there that says Contact Sales. I think that's actually an excellent source to be able to get information. And hopefully you actually are interested in working with us in a partnership. But in any case, it's a good place to go and get some more information about what is our network coverage, you know, what kinds of messages do we get, where, you know, all those things you'd want to know about our notifications, as well as, you know, how does this interact with the rest of the product suite? How do I get other types of data that I need that you guys may or may not have? Please feel free to utilize that as a site. I could spend all day just talking about that, and it'll just be an infomercial, which I don't think is what we signed up for. But we do have a lot of that information. Very happy to share it, regardless of where you'd like to go beyond that. I did notice a very PCP-centric question, and I myself don't know the answer at all to it. Is there a legal responsibility for PCPs or other specialists to respond or act on ADT notifications? Do they need?
I saw that question too, and I was trying to answer it, but couldn't figure out how to get Zoom to work for me. I do not believe there is. No, I don't think there's any legal requirement. There are very few legal requirements in medicine. Unfortunately, when they come in, it's legislators trying to tell us how to practice. But no, it's really up to. I think in a value-based care arrangement, there are certainly going to be rules and suggestions and structures put in place. But yeah, as I say, I think a lot of my PCP colleagues don't even open their messages for ADTs. It's like, you know, I'm going to wait until they come in the door and I'll deal with it then, because they just don't have the time for it.
Yeah, that's my understanding as well. Unless, of course, they are billing for TCM services, then potentially, of course, they have to be doing the follow-up within the certain amount of time. But yeah, unless they are choosing to do that themselves, that's my understanding as well, so there's no other requirement for them to be following up.
That's right. All right, folks, we are right at time. We still had a few other questions in the Q&A. What I would encourage is for anybody who wants to follow up, you can use that contact sales button. You can also reach out to us. We're all very accessible on LinkedIn and other places. I'm Asnaani at healthgorilla.com, for example. Feel free to reach out. Happy to answer. I think we got the spirit of most of the questions here, if not the detailed responses. So hopefully everybody leaves here feeling like they learned something out of this and they got funded out of this. But again, if there are any other questions, please feel free to reach out. I want to thank our panelists so much for joining us. Chris, Farah, Dr. Lane, always a pleasure to have you guys here talking to me. Actually, this is such a wonderful opportunity to do this, like actually in a webinar. Otherwise, and just since HIMSS, we've not had this opportunity. So I really appreciate it. And I think I'll let everybody go and have a great, rest of your Wednesday, rest of the week. And hope everybody found this meaningful and fun.
Thank you.
Thank you.